This is the first part. We'll only have two parts about the autoimmune collagen disorders. First, let's agree on the description, the nomenclature of this chapter. I prefer the word autoimmune collagen disorders to connective tissue disorders. I don't want you to be mixed up with disorders of the connective tissue like reactive perforating collagenoses or erythematosus perforans serpiginosa, where there are disorders of the collagen and elastin. This chapter deals with the autoimmune collagen disorders. We'll start with lupus erythematosus, the major part of this chapter. Start with the definition. This is an old definition in old medicine books and still valid up till now with some modifications. It is an autoimmune collagen disorder. This means that the immune system of the body attacks the collagen. It is precipitated in genetically predisposed persons, so we have genetic predisposition, by a variety of factors. So we have precipitating factors like the ultraviolet rays, drugs, estrogen, unknown virus infection, and psycho-emotional distress. So again, to understand any disorder, we have to search for the etiopathogenesis. This is where we can jump in to block the progress of the disease if we understand. We started in the definition with saying that lupus erythematosus is a genetically predisposed person. This we have nothing to do. We cannot stop. Maybe we can give some advice. How do they know the genetic predisposition? Familial tendency is very old with the just early observations, maybe a century before. The observation led us to know that it's a polygenic mode. You cannot find a specific pattern like autosomal dominant or autosomal recessive when it is just tied to one gene. But they know that the human leukocytic antigen DR4 persons are slow acetylators and they are more prone to develop lupus erythematosus. How this is going to happen, we'll discuss to the slow acetylation. Ultraviolet ray is the triggering factor in most of the cases. How does it do that? Ultraviolet rays is electromagnetic waves and they are loaded with energy particles, the photons. Delivering this energy into the human skin leads to upregulation of antigen expression, meaning I may have a dormant antigen, and with the energy gained by the ultraviolet ray exposure, this energy will be more expressed, so it stimulates the immune system. Upregulation of cytokine release. Ultraviolet rays in high doses may lead to release of enzymes and cytokines and release of oxygen-free radicals with the induction of inflammation. Release of sequestered antigens, meaning that if I have protein, self-protein, it may be broken, sequestered by the energy of the ultraviolet, and therefore it becomes foreign, stimulating an autoimmune reaction. Release free radicals, we just said that. Externalization of an internal antigen. This is very important. A self-protein is self when it is present in its place. If it moves outside its place, then it's foreign. Example of this is the externalization of internal proteins inside the cell by the exposure of ultraviolet rays and stimulus zero antibodies, like what happens in subacute lupus erythematosus. Outside lupus, I'll give you a simple example. When a patient comes to me with pseudofolliculitis barbae, the hair inside its canal itself, when it penetrates the canal or it emerges out of the skin and then reinserts itself again into the skin, it induces a foreign body reaction. My hair is foreign to me if it leaves its place. This is what happens with self-proteins after gaining the energy of the ultraviolet and leaving their place and moving to another place. This is one of the mechanisms of induction of autoimmune reactions by ultraviolet rays. Other factors. Estrogen is important in the induction of the systemic lupus erythematosus. It was first observed that lupus erythematosus is more common in females than males. Systemic lupus is more common, 8 times more common in females than males. Subacute cutaneous lupus may be 4 times in females up to 1 male, and discoid lupus 2 to 1. Lupus erythematosus is worse with pregnancy and with contraceptive pills containing estrogen, and those females are usually slow acetylators. Again, drugs that induce lupus erythematosus in patients that are prone to induction of lupus erythematosus, genetically prone, and they are slow acetylators. What is this issue of slow acetylation? Acetylation is one of the mechanisms where the liver detoxifies or gets rid of unwanted chemicals inside the body, be it hormones, be it drugs, be it whatever. If the liver is slow to acetylate these circulating chemicals, they accumulate in the blood, they reach high level above the threshold needed to induce the inflammatory reaction. With drugs, there is a specific pattern of autoantibodies, the antihistone antibodies in most of the drugs, and the anti-double-stranded DNA with etanercept and penicillamine. The list of drugs accused of inducing lupus erythematosus seems to be unlimited, but these are the most famous drugs up till now. Nevertheless, any drug may prove to induce lupus erythematosus in the near future that we don't know. Anecdotal reports are multiple, but here are the most famous drugs: hydralazine, hydrochlorothiazides, ACE inhibitors, calcium channel blockers, spironolactone interferons, piroxicam, glycofulvin, penicillamine, and etanercept, as we just said. Glycofulvin increases the tendency of normal people to photosensitivity. So again, people who are susceptible to lupus erythematosus with glycofulvin will show the anti-Rho antibodies and will show photosensitivity and the induction of lupus erythematosus, and therefore glycofulvin is absolutely contraindicated in patients in whom we know there is a history or active lesions of lupus erythematosus. Now, the story of the unknown virus. This is a very old story, with the old days when even before the development of the electron microscopy as a diagnostic tool. They discovered abnormal structures inside the cells in the virus-infected cells. These structures are either in the cytoplasm, cytoplasmic inclusion bodies, or in the nucleus. And they are formed of very fine microtubules arranged in a reticular form, tubulo-reticular structures. They linked this to an unknown virus. They were not able to identify the virus, but they said this is part of a viral infection of a cell. More recently, I'm saying more recently, this is something like 30 years ago. More recently, they discovered that the tubulo-reticular structures present in a cell are a sign of abnormal function of the cell. This does not rule out an unknown virus infection, but it makes it not confined to a viral infection. So still, virus infection, unidentified, may stimulate, may precipitate the induction of lupus erythematosus in genetically predisposed persons. Psycho-emotional stress actually precipitates any disorder and makes any disorder much worse. The role of neuropeptides, ever searched in many disorders, proved to be very valuable in induction of inflammation, in lowering the immunity to infections, and in promoting the overreaction in autoimmune reactions or autoinflammatory reactions. Now, the final common pathway is the altered immune response. Whatever the inducing factors are in a genetically predisposed person, the final pathway the damage occurring through an altered immune response. The major change here is the reduced T suppressor function. T suppressor cells here is the control mechanism for the immune system. With a reduced function, there is a reactionary overfunction of the T helper, stimulation of T helper cells, which stimulate again the B lymphocytes to turn into plasma cells to induce autoantibodies. So there is overproduction of immunoglobulins attacking collagen, and there is reduced clearance of immune complexes. This is a reduced function of the macrophages. Complement-mediated damage, you have to revise both the classic and the alternate cascades of complement activation. Please remember that complement 3A and 5A are chemoattractant and stimulant to both basal cells, basal lymphocytes, and to mast cells and to neutrophils. And complement 5A through complement 9A, they form membrane attack complex. Complement deficiency here is a syndrome that may be associated with lupus erythematosus in any form of the systemic lupus, discoid, or subacute cutaneous lupus, mainly subacute cutaneous lupus. Now, clinically, cutaneous lupus erythematosus is classified into chronic cutaneous lupus erythematosus, subacute, and acute cutaneous affection in lupus erythematosus. Classification of chronic cutaneous lupus erythematosus, we have to remember this by the heart. We have discoid lupus erythematosus, which may be localized above the neckline, affecting the face, the ears, the scalp, or generalized, affecting above and below the headline. It used to be called disseminated discoid lupus erythematosus. We have the hypertrophic discoid lupus erythematosus, where the lesions are verrucous, they acquire the verrucous shape, and in some cases, especially if it affects the lower lip, we have to differentiate between verrucous lupus erythematosus or verrucous squamous cell carcinoma arising on a long-standing lupus erythematosus of the lower lip. We have the lupus erythematosus lichen planus overlap syndrome, where the lesions clinically, histologically, and by direct immunofluorescence are mixing together, meaning that I have lesions of lupus and lesions of lichen planus, showing the classic criteria of each of them. This is a true overlap syndrome. We have the chilblain lupus erythematosus. Strange enough, chilblain lupus erythematosus is more common with discoid lupus erythematosus than with systemic lupus, where they have in systemic lupus erythematosus, we have more extensive vascular changes than in discoid lupus. But we have chilblains here in some patients with discoid lupus erythematosus, especially in children. Now, the difference between tumid lupus erythematosus and LE lupus erythematosus profundus. Tumid lupus erythematosus affects the dermis. So we have edema, mucin deposition, inflammatory infiltrate, mainly lymphocytes, in the dermis. And changes in the epidermis are secondary to what's happening in the dermis. While LE profundus, we have the affection in the subcutaneous tissue, in the connective tissue septa, between the fat lobules. Tumid lupus erythematosus is to be differentiated from reticulate erythematous mucinosis, and some references refer to both as synonyms. They are one and the same disease. While in LE profundus, the overlying skin may show discoid lupus erythematosus, may show changes suggestive of subacute cutaneous lupus erythematosus, or may be clinically normal. Tumid lupus erythematosus and LE profundus may be associated with systemic lupus erythematosus. Here are some photos from the internet. Here we see the classic picture of discoid lupus erythematosus affecting the butterfly area, facial, persistent facial erythema with scaling, telangiectasis, and the scales are adherent here. And we can see even some scarring occurring within the lesions. Here affecting the external ear and the skin around it. Here another lesion at the face with erythema, telangiectasia, and starting atrophy. Here affecting the scalp, the ear, part of the neck, and the face. Scarring is evident, erythema is persistent, scales are adherent. Here affecting the scalp. Again, another lesion. Here we see a tumid form with the inflammation deeper and the affection of the epidermis is less than what we have seen before. Swelling and erythema are persistent here and in a sun-exposed area. In subacute cutaneous LE, we have mainly two clinical presentations, either psoriasiform pictures, papillosquamous, where we have the erythema and the scales, or the annular form, the inflammation is deeper, the edema is deeper, and it looks like the figurate erythemas or a persistent form of urticaria. And you have the syndromes. Neonatal lupus erythematosus presents with the picture of subacute cutaneous LE. We have the complement 2 and 4 deficiency, as we said before, and it presents in the clinical form of subacute cutaneous LE. And we have the drug-induced LE. In most of the cases, it presents in the form of subacute cutaneous LE. Clinically, papillosquamous, annular with photosensitivity and favoring the photo-exposed areas. Now we are left with acute cutaneous LE, usually comes with systemic lupus erythematosus. We have generally two types of skin lesions, either specific or non-specific. When we say specific, we mean it shows the characteristic specific histopathological changes. Non-specific, so by biopsy you cannot say whether this is lupus erythematosus or not. Like when you have gangrene or necrotic changes and you cannot find the classic picture of lupus erythematosus, when you have subepidermal blisters without the characteristic infiltration or something. Now, back to the clinical picture of discoid lupus erythematosus. I love the classic characterization of discoid lupus erythematosus. They used to teach us when we were young students that a lesion of discoid lupus erythematosus has 5 cardinal clinical characters in each lesion. At least 3 of them, with at least 3 of them, you can diagnose discoid lupus erythematosus with a high degree of confidence. Number 1 is persistent erythema. Persistent is very important. And when I ask someone what are the characters of discoid lupus erythematosus and he starts with hyperpigmented patch, actually this annoys me very much. It's called erythematosus. There is erythema, and erythema is persistent here. It's not just some photoallergy or some burn that goes in 1 or 2 days. It's persistent. And this persistent erythema, meaning there are persistent vasodilatations, so you have around the lesion telangiectasia, loss of collagen support, and dilated capillaries. Inside the lesion, we have the adherent scales that are adherent on a pilosebaceous orifices. What actually happens here is atrophy of the pilosebaceous unit, and we have a keratotic plug. When we remove the scale, it's adherent, and we remove it with difficulty, and we find some keratin and sebum admixture like a carpet tag nail. So the scale is wide and tapered nail down at the undersurface. And this ends by scar formation. Healing here is by scar formation, which the scar may show some dyspigmentation, whether hyper or hypo. So please, when I ask you the characters of the discoid lupus lesion, don't tell me hyperpigmented. It is erythematous, it heals by scar, that may be hyper or hypopigmented. So applying the clinical picture that we have seen to the histopathology, when you see the clinical picture and when you understand the basics of histopathology, you can expect that in this lesion there is hyperkeratosis with epidermal atrophy. You cannot expect this, but you have to know that there is hydropic degeneration of the basal cell layers and the thickened basement membrane. In the epidermis, there is keratotic plugging of the pilosebaceous orifice, we just mentioned that, and down there is atrophy of the pilosebaceous units. It's persistent erythema, so we have dermal papillary vasodilatation. It's an autoimmune inflammatory collagen disorder, so we have periappendigeal T cell infiltrate, and there is hydropic degeneration of the basal cell layer, so we have civet bodies and melanophages in the upper dermis, and we have mucin deposition in the dermis. So actually, if you understand the background of the clinical picture, you can just tell 7 out of these 10 characteristics histologically. Here are some photos from the internet showing the hyperkeratosis, the scales, the perivascular and periappendigeal infiltrate, and the dilated blood vessels. Here you see again some homogenization of the collagen surrounded by the inflammatory cells. Again, a higher magnification. And here showing the colloid or civet bodies in the upper dermis. Again, the inflammatory infiltrate and the hyperkeratosis. Now, back to the subacute cutaneous LE, photosensitivity is most marked. Actually, the history that we see with the patients of subacute cutaneous LE always, let's say, mostly relates to increase in the exposure of the ultraviolet rays, a sudden increase, an acute increase, like what happens when the spring comes. In the winter, we are all covered. Spring comes, it's a nice day, so we go to one of the gardens or the beaches and we play in the sun, we are exposed. In 24 to 48 hours, the rash is complete on the exposed parts. Here there is an acute increase in the dose of ultraviolet energy delivered to the skin. Photosensitivity here is most marked. This inflammation is subacute, it's not chronic. With the chronic lupus erythematosus, the lesions are localized to the skin and they are destructive. They heal by scarring. Here, subacute. So we see the edema, the erythema, and the induction is sudden, acute, and the lesion stays for a few weeks, it's subacute, and it heals with no scarring, but maybe with some dyspigmentation. This is an intermediate form between the discoid chronic lupus erythematosus and the systemic lupus erythematosus. So in 20% of patients, some lesions may end up by the chronic localized destructive discoid lupus erythematosus lesions. 75% of the patients may have associated or develop later on arthralgia. Antinuclear antibodies are positive in 80% of the patients. 20% of the patients show hematologic changes with leukopenia, and 30% fulfill the American College of Rheumatism criteria for systemic lupus erythematosus. And this is one major defect in the criteria put by the American College of Rheumatology, and that was later on, recently, it was modified, as we'll see. They have the positive HLA-DR3, which correlates with the photosensitivity and the raw SSA, La SSB autoantibodies. Here is part of the rash. Scaly erythema is evident here, and some annular lesions too are present. We have both types of lesions here. These are the annular lesions of subacute cutaneous LE in a scalp. So histopathologically, since we have scales, so we may find parakeratosis, or we may have the autokeratosis if we don't have the scales. We have hydropic degeneration of the basal cell layer with upper dermal edema and T-cell infiltrate. We have upper dermal mucin and colloid bodies. We don't speak here about the epidermal atrophy, the pilosebaceous unit atrophy, or the keratotic plugging. This lesion is more acute than the discoid lesions. We haven't reached the stage of atrophy or hyperkeratosis, hyperkeratotic plugging of the pilosebaceous offices. And now we are left with the histopathology of systemic lupus erythematosus. And as we mentioned before, we have either specific lesions that show the histopathology, the characteristic histopathology of lupus, or we have the non-specific rash. We cannot diagnose from the biopsy that this case is lupus erythematosus. Again, here we have the edema, the mucin deposition, the inflammatory infiltrate, and we have the hyperkeratosis with some parakeratosis. The same. In systemic lupus erythematosus, we see the edema, the mucin, and the infiltrate. Now, neonatal lupus erythematosus occurs in a newly born infant. The infant is born normal, showing no disease. The disease here is triggered, is precipitated by the transplacental passage of maternal immunoglobulins, especially raw SSA antibodies. The mother may have systemic lupus erythematosus, subacute cutaneous lupus erythematosus, Sjogren's syndrome, we are talking about the raw SSA antibodies, or mixed connective tissue disorder. The mother may have any of these diseases active or latent. The patient may not show the disorder. She will have the antibodies and she will be suffering from some symptoms in a subclinical form that is not clearly diagnosed as one of these collagen disorders. The newborn is free and the rash appears within weeks and fades within months, usually 6 months. The body, the neonatal body, gets rid of the mother autoantibodies. Therefore, he is not forming the autoantibodies, so simply gets rid of them. But the problem here is if this syndrome affects the heart or the liver. These changes may be permanent and may affect the life, may lead to death, whether heart block or liver fibrosis. As we mentioned before, complement deficiency syndrome, usually complement 2 and 4, they may be isolated or with systemic lupus erythematosus or subacute cutaneous lupus erythematosus serologic profiles. They lead to picture like the subacute cutaneous lupus erythematosus, clinical picture like them. Complement 2 deficiency is usually associated with tendency to serious microbial infections, and complement 4 deficiency is usually associated with pulmonary hyperkeratosis. These are some clinical clues to diagnosis. So now we are left with the 11 criteria of the American College of Rheumatology or American Rheumatism Association for diagnosis of systemic lupus erythematosus. Classically, 11 criteria, 4 of them were enough for sure diagnosis of systemic lupus erythematosus. As we mentioned before, these criteria, if we take only 4 of them, we can include dermatomyositis and subacute cutaneous lupus erythematosus in the diagnosis, erroneously included in the diagnosis of systemic lupus erythematosus. So we'll see the modification on them now. But let's first try to remember by the heart the 11 criteria. The first 4 are skin lesions: discoid lupus erythematosus, malar erythema, photosensitivity, and oral ulcers. So we are talking about skin lesions in the area of the face and mouth. The second 4, we are talking about organ affection: arthralgia and arthritis, Serositis here meaning pleurisy and pericarditis. Nephropathy, affection of the kidneys, and neuropathy, whether central or peripheral nervous system affection. So, 4 criteria in the skin and mucous membranes, 4 criteria in organs, and 3 laboratory investigations. One of them is hematological changes. We talk about changes in the blood picture, whether ESR elevated, leukopenia, or whatever, hemolytic anemia sometimes. Number 2 is immunologic markers, anti-double-stranded DNA, anti-SM, anti-RNA, anti-Rho, anti-La, all the battery of investigations that we know about the lupus erythematosus. And number 11, by itself, anti-nuclear antibody. So we put all the other immunological markers in one item, and the anti-nuclear antibody alone is in one item. It's very important. This is the most sensitive for the autoimmune collagen disorders. So screening a patient, we start with hematologic disorders. We make a CBC, and we make anti-nuclear antibody. If you want to add, maybe you add anti-double-stranded DNA, because it's very important, associated with kidney affection, and this is the major cause of death in patients with lupus. In anti-nuclear antibody, when you ask the lab to get you the titer and the pattern of it. These are very important, both of them. If the lab gives you anti-nuclear antibody positive 1/80, sorry, it's negative. 1/40, 1/80 is not diagnostic. You start suspecting 1/160, and it is diagnostic 1/320. Systemic lupus erythematosus affects all the organs of the body. Now there is a modification of the criteria. Instead of choosing any 4 of the 11 haphazardly, no. The Systemic Lupus International collaborating clinics, they modified the choice of the criteria. Yes, we have at least 4 criteria, but at least one of them is clinical and one is immunologic. So you don't give me the 4 skin lesions and you say this is systemic lupus erythematosus. No, you have to include one of them at least immunologic pattern. Or, to be more invasive and more decisive, biopsy proven lupus nephritis plus anti-nuclear antibody or anti-double-stranded DNA. These are the modifications added to the 11 criteria of the American College of Rheumatology. Cutaneous manifestations of systemic lupus erythematosus are numerous. Some are specific, some are non-specific. Let's read them together. We have the malar erythema sparing the nasolabial folds. Yes, as you have seen in the picture, maybe of the discoid lupus, even the nasolabial folds tend to be spared. They are partly covered from the ultraviolet damage of sun rays. We have mucosal lesions, eye, nose, mouth, and vagina. Don't forget this. We have the vascular lesions that end up in necrotic areas, telangiectasia, or capillary loops in the periangual folds. We have the lupus hair with long-standing lesions. We may have calcinosis cutis. We have papillonodular mucinosis. We have mucin deposition, as we said before, in all the forms of lupus, that we may have this looking clinically in the papillar or nodular mucinosis form. Now, this entity is rare but very important to remember and to know. Bullous lupus erythematosus with subepidermal blisters, and the infiltrate here is mainly neutrophilic rather than lymphocytic. And we have the Rowell syndrome. Rowell described the association of systemic lupus erythematosus with erythema multiforme. Here is the malar erythema sparing the nasolabial folds. Here is the oral affection. So, what to do with the case of lupus erythematosus? When you suspect, start with the complete blood picture and ESR and the Wassermann test. The non-specific test for syphilis should be positive in most of the cases of lupus erythematosus because they have the anti-cardiolipin antibodies, which is part of the antiphospholipid syndrome. Again, antinuclear antibodies use search for the titer and the pattern. The shrunken peripheral pattern indicates renal affection. It goes in conjunction with the anti-double-stranded DNA. While the particulate, as we mentioned before, goes with subacute cutaneous LDE, and it goes with the anti-Rho antibodies. We may have the homogeneous pattern antihistone antibodies that is positive in most of the drug-induced lupus erythematosus. We may ask for the anti-double-stranded DNA, anti-SM, which is the most specific. It's not positive with any other disorder apart from lupus erythematosus. Nevertheless, it's positive in less than 20% of cases of lupus erythematosus. We have the anti-Rho Sjögren syndrome SSA, and anti-La. It usually follows the anti-Rho. You don't have to ask for it. They are mainly positive in the subacute cutaneous LE, neonatal LE, complement deficiency syndromes, and with photosensitivity, as we explained before. Anti-ribonucleoprotein is characteristic for mixed connective tissue disease. We ask for it when we doubt that this is not a case of lupus erythematosus or dermatomyositis. It looks like to be mixed. Anti-ribonucleoprotein is positive here. And the antihistone antibodies with the drug-induced lupus. Of course, this patient is not going to suffer or die from the autoantibodies without affecting the kidney, the liver, the heart, and the lungs. We have to look for the well-being of the patient, and we have to investigate the internal organs according to the guided by the clinical picture of the patient. Lupus band test is a classic test. It shows granular linear deposits of immunoglobulin G or M along dermoepidermal junction. This test is positive in 75% of long-standing active discoid lupus erythematosus lesions. Here we say long-standing and active. You don't take a biopsy from a scar and expect to find it positive. It's positive in 1/3 of the lesions and the non-lesional sun-exposed skin in subacute cutaneous LE patients. It is positive in lesions and non-lesional sun-exposed and some protected skin in active systemic lupus erythematosus patients. It shows the reaction, the O2 antibodies attacking the collagen at the dermoepidermal junction. In subacute cutaneous LE and in systemic lupus erythematosus, it correlates with anti-double-stranded DNA, and this is why recently this test is not performed as frequently as it used before, because the anti-double-stranded DNA gives a clue to what's happening. We don't need to do the lupus band test, which needs special lab preparation. We don't need to do it anymore in most of the cases. But it still retains its value for research. Now, we heard a lot about the antiphospholipid syndrome, the lupus anticoagulant, and the anticardiolipin. Antiphospholipid syndrome is the title, is the syndrome that has many subtypes, like the lupus anticoagulant and the anticardiolipin. So, what is the story of the antiphospholipid? This autoantibody attacks the phospholipid content of the endothelial cell walls. So, it breaks it. Healthy endothelium releases prostacyclin, which is a prostaglandin responsible for vasodilatation and prevention of platelet aggregation. So, when these endothelial cells are attacked by the antiphospholipid antibody, the cells stop releasing the prostacyclin, and the subendothelial collagen is exposed. This leaves the blood circulation in these affected vessels under the effect of the thromboxane, which is another prostaglandin released by the platelets, leading to platelet aggregation and vasoconstriction. This is how thrombosis, intravascular thrombosis, occurs by the antiphospholipid syndrome. It attacks the endothelial cells, so the endothelial cells stop to function as vasodilatation and prevent platelet aggregation. The consequence is vasoconstriction and platelet aggregation, starting thrombosis. The result is intravenous thrombosis, peripheral gangrene, placental infarct, abortion, intrauterine fetal death, or antepartum hemorrhages. And this leads us to the dilemma of systemic lupus erythematosus and pregnancy. I ask my colleagues, my students, to think widely. You are having a female patient known to have systemic lupus erythematosus, and they come and consult you and ask you, should she get married? And if she gets married, should she get pregnant or not? What are the consequences? So you have to think widely. Number one, if the disease is long-standing and affecting the internal organ, there may be reduced fertility of this female patient. If the fertility is good, we may allow pregnancy if the disease is under control and the internal organs are well compensated, because actually the disease may worsen with pregnancy, and the mother vital system will suffer from the burden of the new creature inside her. So we have to keep very good monitoring and care about our female patient. Lupus anticoagulant may lead to abortion or antepartum hemorrhage with placental infarct, so they may need anticoagulants, something like aspirin or something, under the observation of the internal medicine doctor and the gynecologist. And we observe the newly born for neonatal LE because it's a possibility. If the rash occurs, we do not relax and say it will go by itself, it's self-limiting. No, because now we know that there could be permanent affection of the heart or the liver. Complications of lupus LE. If discoid lupus LE, we have scarring, atrophy, and on long-standing scars or atrophic areas, squamous cell carcinoma may develop. We have to be aware of that. With systemic lupus erythematosus, complications are much because many organs, most of the organs, are affected. Death here usually comes from renal, cardiac, or central nervous system affection. So it's not the task of the dermatologist to take care of the patient alone. You have to work in conjunction, in perfect coordination with other specialties. You diagnose, maybe you are the first one to see the patient to diagnose, but you need other specialties, doctors, colleagues, and friends to help you to pass the dilemma of systemic lupus erythematosus of this unfortunate patient. I leave you now to search in your references for the treatment of discoid lupus erythematosus, subacute lupus erythematosus, and systemic lupus erythematosus. Go for the major outline of the treatment, and remember always that use other specialties, help when you need. Don't take the whole burden for yourself. Most important is to diagnose the patient, and then we can look for the treatment together with other colleagues. I'll leave you with this case. Actually, I faced this patient early in my clinical career. She was a teenage female presented with recurrent attacks of urticaria and angioedema with few wheals persisting more than 48 hours. It looks very naive at the beginning. Occasional low-grade fever, moderate hair loss, and moderate depression. This can happen to anyone. This patient turned out after 5 years to be full-blown picture of systemic lupus erythematosus with kidney affection. Please take care. Do not frighten the patient, but I want you always to be scared and think widely for the possibilities. And thank you very much.